This is Dr. Robert Emmons, current president of the Kentucky Society of Clinical Oncology, or KYSCO. KYSCO is a physician-led organization whose mission is to ensure the highest standard of cancer care in Kentucky through education and advocacy. Through these means, our vision is to promote the most effective cancer therapies and improve access to care and enrollment in clinical trials in the state of Kentucky. If you're a cancer professional in Kentucky, KYSCO is your organization, and membership is free. We hope you will review our website at KYSCO.org, participate in upcoming meetings, and use the statewide clinical trials database available on the web, and take advantage of our educational content, including this podcast series. We want to hear from you, so please reach out through the website for any comments. And thank you for listening to KYSCO Oncology Voices.
Welcome to KYSCO Oncology Voices, your source for all things patient care and practice management in Kentucky oncology. I'm Shreyas Kalantri, Chief Fellow at University of Louisville, Brown Cancer Center, and your host for this episode. Every other month, we deliver everything you need to know to continue providing the highest standard of cancer care to patients across Kentucky. Today, we are diving into key updates in non-small cell lung cancer with a spotlight on major trials from ASCO 2025 and how their findings apply to our practices here in Kentucky. I'm joined by two expert thoracic oncologists from University of Louisville and Baptist Health, Dr. Goetz Kloecker and Dr. Firas Badin. Dr. Kloecker and Dr. Badin, thank you for both being here. Would you like to briefly say hello before we jump in?
Thanks, Shreyas, for inviting us.
Yes, thank you so much. It's my absolute honor to be with you and my colleague, Dr. Kloecker.
Yeah, we are glad to have you here. So before we begin, a quick reminder that Kentucky has one of the highest lung cancer incidence and mortality rates in the nation. While we are making progress in screening, we face unique challenges in implementing advances across our community and academic practices. So let's get started. Dr. Kloecker, can you give us a brief summary of CheckMate 816 trial, its design, what it tested, and the key outcomes?
Yeah, so this is really a landmark trial, and they just presented the 5-year overall survival data ASCO this year. And it's remarkable because it's a neoadjuvant chemo-immunotherapy trial in early stages that are resectable. They shouldn't have an EGFR mutation, but they were allowed to have any kind of PD-L1 expressions. So non-expressor or high expressor, regardless, would qualify for 3 cycles of chemoimmunotherapy using nivolumab as the immunotherapy and then the chemotherapy of choice. And it was randomized versus the chemotherapy alone. After 3 cycles, patients went to surgery. After the surgery, their pathologic response was evaluated, and then it was up to the doctors to choose adjuvant chemotherapy depending on the pathologic response. This study is remarkable in many ways. There was no problem with surgery itself, so we didn't make the surgeons unhappy. The timing to surgery went well. The surgery had no higher complication. The patients recovered from the surgery well. So no problem there. One has to say, whenever you do neoadjuvant, there are some patients who will not make it to surgery. So there was roughly 10 to 16% who couldn't make it to surgery. But you know, this happens even if you don't do neoadjuvant chemoimmunotherapy. There is progression of disease, comorbidities. The patients just don't want to have the surgery. So it really hasn't changed very much the number of patients who actually go to surgery for an earlier resectable lung cancer. Now, the remarkable part was when you compare the arm with neoadjuvant chemoimmunotherapy. And remember, these were only 3 cycles, so it took 9 weeks. They had a pathologic complete response in 20% with the chemoimmunotherapy versus 2-3% with chemotherapy alone. And then when you look at the outcome, and this is now 5 years later, the survival was clearly better overall for all comers 10% of people were more likely to be alive at 5 years. And the people who had a pathologic complete response, they were event-free for the years to come. So for at least 2-3 years, they didn't have recurrences in 95%. So that is really a landmark trial and set the stage for a lot of other neoadjuvant trials, and will also change our practice in the future dealing with early stage lung cancer.
Thanks for that, Dr. Kloecker. Thanks for that. Now I want to unpack how this is actually playing out in Kentucky. So first I would like to ask is, how has neoadjuvant chemo-immunotherapy changed your multidisciplinary coordination, especially with thoracic surgeons?
Well, as I said, it's a game changer. It's like serving the dessert before the main dish. I mean, the surgeons are used to cut it out, and then they send us patients for adjuvant therapy. Now we should see the patients initially when they're resectable, should be evaluated for neoadjuvant treatment. And it changed our practice, not just in the university setting. Dr. Badin will comment about this in the community. These patients are presented at tumor board or immediately referred from pulmonologist after the biopsy to the medical oncologist. So it changed the whole organizational workflow, I would say.
And for patients with high PD-L1 expression, how do you see any role for neoadjuvant immunotherapy as a monotherapy instead of chemo plus IO that we have been doing?
Well, I hate to extrapolate data from the metastatic setting. KEYNOTE-24 in high expressors single-agent immunotherapy had a very good effectiveness, but honestly, I don't think we can apply this to the curative setting where chemotherapy, and we know this from the adjuvant trials with chemotherapy, clearly had a survival benefit. So even high expressors, I would not let go of the chemotherapy.
And you mentioned about the complete pathological response that was achieved in a good number of patients. So do you think adjuvant therapy is needed in these cases? Is there a role for de-escalation?
Well, I just had a patient last week exactly with 100% pathologic complete response. And I showed him the data. I showed him the survival curve of 90-95%, and said, you know, I don't know if immunotherapy for another year will add anything. I mean, you had a great response. But, well, guess what he chose? And it's really shared decision-making. I would not withhold the immunotherapy. I think the patient should decide. He tolerated well, and he chose to go for it for another year. And other patients may say 95% is good enough. Let it be.
That makes sense, yes. And Dr. Badin, from a community standpoint, how do you approach biomarker testing and timing? Is there concern about losing surgical windows while waiting for the result? Have you experienced any pushback from thoracic oncologists, or it has gone well with the current findings?
Well, first of all, thank you so much, Dr. Kloecker, for the excellent summary of important trial 816. I always enjoy listening to Dr. Kloecker. You know, on a personal level and professional level, I think his insights always impactful and very helpful. For 816, we've been doing this. It has been our standard regimen. And like Dr. Kloecker said, it's only 3 cycles. And while 3 extra weeks for the 4th cycle may not sound a lot, but to be quite honest with you, for patients as well as for surgeons, I think having not to do the 4th cycle and having not to wait longer than they should, it will make surgeons feel better that they operate earlier, as well as patients are not waiting as long as if we have to do 4 cycles. Also, from our experience, it seems like the 4th cycle is where a patient might have a complication. A lot of chemotherapy toxicity is cumulative. While I think it's safe and feasible to do 4 cycles, but if you can omit the last one and stop at 3 cycles, I think patients enjoy that, as well as surgeons. how can we capture those patients? Because the trick here is to be able to administer this before they get into surgery. And what we've been doing, we discussed those cases at our tumor board or MDT clinic. And I think there has been one positive study after another, and different drugs got approved in the neoadjuvant stage that really cardiothoracic surgeons as well as pulmonologists are really aware about neoadjuvant data and tend to send those patients to medical oncology before going into surgery. When it comes to testing, luckily, all those drugs, immunotherapy agents in neoadjuvant setting are approved regardless of PD-L1 expression, whether it's positive or negative, or strongly positive, we can use neoadjuvant therapy.
Thank you for that, Dr. Badin. Thank you. And as we know, multidisciplinary collaboration is extremely important, especially in the field of oncology. And I'm glad everybody is up to date and on board with this advances and is doing everything they can for the patients. So moving on, Dr. Badin, could you walk us through the NeoADAURA trial briefly? What was studied and what were the main findings that you noticed?
Yes, absolutely. So staying in the neoadjuvant space, so we have now the addition of immunotherapy. We have 3 different checkpoint inhibitors approved in neoadjuvant addition to chemotherapy. But we know patients who have EGFR mutation or really any driver mutation, they don't draw the same benefit from immunotherapy like other patients. So this is definitely an area of unmet need. When we have somebody who is EGFR positive and you capture that before surgery, what should you do? Should you do neoadjuvant chemo alone? Should you do neoadjuvant chemo plus targeted agent, or should you do targeted agent alone? And that's what the NeoADAURA trial tried to answer. And now we, after having the ADAURA data showing that adjuvant targeted therapy, adjuvant osimertinib, in patients with metastatic, in patients with resectable EGFR positive, we can use adjuvant OC for 3 years with significant improvement in survival and hazard ratio about 0.49. So more than 50% reduction risk of death. So maybe if we can adopt OC in neoadjuvant setting, also we can have similar results, similar benefit. So NeoADAURA was presented at ASCO 2025. They looked at patients who have resectable lung cancer, stage 2 as well as stage 3, randomized 1:1:1 ratio, so 3-arm study, either neoadjuvant chemotherapy, also 3 cycles here, platinum, either cis or carbo with Alimta, versus with placebo, versus the same chemotherapy plus osimertinib at the current FDA-approved dose, 80 milligram daily, versus osimertinib alone, 80 milligram daily. The patients got 3 cycles, then went into surgery. So again, this is something really novel that we haven't done before. And the primary endpoint here with the study, they were looking at a major pathologic response, not a complete pathologic response, major pathologic response, which by definition less than 10% viable tumor at the surgical specimen. And the study showed significant improvement in major pathologic response, or MPR. It improved from 2% alone chemotherapy to 25% with the OC arm, and then 26% with osimertinib plus chemotherapy arm. So significant improvement in the primary endpoint. The data is not mature yet, but there is early evidence that there could be separation of the event-free survival curve and the osimertinib arms, OC alone or OC plus chemo, compared to chemo alone. So the study really showed osimertinib with or without chemo, statistically significant improvement in major pathologic response, as well as they look at some other endpoints, including downstaging into disease, was significantly also better with the OC, including arm. So this could be a new standard of care for those patients who are EGFR positive. Obviously, there are a lot of challenges with this patient population. When do you do the testing? Do you have the result back? like we discussed with 816. Are you going to wait for NGS? Is the surgeon going to order the test before we see the patient? Different things. We have MPR data right now. Obviously, we don't have survival data, event-free survival, OS data. That should be coming hopefully next. But nevertheless, I think for those patients that we don't have a neoadjuvant chemo IO option for, or we know the chemo IO may not be ideal for those patients, now based on this data, you can probably consider doing OC alone, OC plus chemo in the neoadjuvant setting.
Thank you for the excellent summary, Dr. Badin. Quick question I had was, considering that the NeoADAURA trial showed similar pathological responses with or without chemotherapy, do you interpret that as chemo may not always be necessary in EGFR mutant cases, if you could use just osimertinib alone?
You know, it's a very interesting observation that the MPR rate was almost identical, 25 versus 26% with OC alone versus OC plus chemo. So it's a very, very valid question. Do we really need neoadjuvant chemotherapy for those patients? Like Dr. Kloecker mentioned with 816, immunotherapy alone versus combination in a neoadjuvant setting and strongly positive PD-L1. Here, the same thing. We know from FLORA2 that addition of chemo to osimertinib really had some impactful benefit when it comes to survival data. So until we have more evidence, I would suggest I'm not ready to omit chemotherapy altogether. Although the benefit might be smaller, but there could be some benefit. But once we have the survival data, I think if we don't really see much difference between the two groups, we can maybe just do neoadjuvant target therapy along with osimertinib and avoid the toxicity of chemotherapy.
That makes sense, totally, yes. And I was wondering now about the real-world implications of this. How feasible is it to start targeted therapy preoperatively in EGFR mutant patients? Are there delays in genotyping affecting care in this?
You know, we need to do a better job in general as a community, oncology community with testing. And I truly believe we are doing a better job. I know back in 2020, when we have some retrospective data analysis that about only half of the patients with metastatic lung cancer are getting tested. I would argue that, today, 5 years later, that number has improved. It's not 100%, and here I'm talking metastatic, but I would imagine that at least 2/3 of patients now are getting tested. And with the addition of liquid biopsy, I think that will make it easier, because really the biggest challenge for gene analysis is the amount of tissue or the availability of tissue. And that will be a concern, actually more of a concern in neoadjuvant setting than in metastatic, in adjuvant setting, where you have a diagnosis out of a biopsy, a smaller specimen, maybe it was an FNA. I don't know if we can have enough tissue to test or not. But before resection, the liquid option is still an option. The other thing is, are we going to wait for the results? Sometimes patients are anxious, sometimes the surgeons are anxious. But given the fact that oncologists as well as surgeons are accustomed to the neoadjuvant approach, I think they will be more open now to NeoADAURA data and do neoadjuvant therapy, especially with the downstaging of N2 disease, maybe having less bulky disease and easier operation.
Yeah, definitely. Liquid biopsy has really made it easier to identify mutations when tissue samples may not always be available. Coming to about your take with the data that is available for ADAURA, will this change the current long course adjuvant osimertinib strategy that we have with ADAURA right now with 3 years of osimertinib?
I really don't think so. I mean, if the patient gets 6 weeks of neoadjuvant osimertinib, when he gets into the adjuvant setting, I think they're still going to get adjuvant OC. Now, duration of therapy, I don't know if we will, it's up to 3 years, but we know some patients might end up with toxicity, some patients might want to stop sooner. The big question is, what about the patients who have, complete pathologic response? And while the major endpoint, the primary endpoint was MPR, a major pathologic response, but they also look at CR, pathologic CR, and I think much lower numbers, maybe about 6% or so get pathologic CR. So I don't know, for those patients, should we push for adjuvant or not, or should we consider monitoring for those patients? And the same question with patients who achieve PCR with chemo-immunotherapy. Do you continue to give them adjuvant immunotherapy for a year or not? It's an area of debate. And as Dr. Kloecker mentioned, for the 816 patients, it's a shared decision-making here. We'll discuss with patients, see their preference, their comorbidities, the type of surgery, number of lymph nodes examined, etc.
Thank you. Dr. Kloecker, what are your thoughts about insurance covering osimertinib in the neoadjuvant setting? Since it's currently only FDA approved for adjuvant, do we need to enroll these patients in trials, or can this be done off-label?
Oh, well, that's a loaded question. Depends on the insurance. And, there's something conceptually very different between neoadjuvant targeted therapy with osimertinib versus neoadjuvant immunotherapy. Neoadjuvant immunotherapy trains your immune system to detect cancer cells and then chase them down and get rid of them. Osimertinib doesn't have that learning effect on your immune system. So it suppresses cancer cells, puts them in a response, and unfortunately, only 6% complete pathologic response. But it would not have these long-term effects as neoadjuvant chemoimmunotherapy. Most of the TKIs work while you give them. They will not eradicate all cancer cells. So you're basically still dealing with 3 years of adjuvant osimertinib. So the neoadjuvant approach is interesting. It satisfies a certain curiosity, how good responses in individual patients. Is it going to be major or complete or not at all? So I think the data is still too immature to make it a guideline. I may, in some situations, consider it. Let's say somebody is unstable because of a heart attack or recent other comorbidity and cannot go to surgery. You could use this approach to buy some time. But whatever the pathologic responses, I would still offer the patient the adjuvant osimertinib. So that's a long answer to a good question. Would the insurance pay for it? It depends what the situation is, and often you have to make an argument with your peer-to-peer discussion. I imagine some insurances will pay for it, and others say wait for the NCCN guidelines till they pay for it.
Yep. That was a very good discussion on NeoADAURA trial. Dr. Kloecker, we also saw some intriguing data at ASCO suggesting that immunotherapy given in the morning may improve outcomes. Can you briefly outline the study design and main takeaway?
Of course, you gave me this abstract or this study to review. This is a tough one, really. This could be a revolution or complete bust. I heard about it. One of your colleagues told me about it, so I listened to the talk. And really, this is a randomized phase 3 trial in advanced non-small lung cancer, randomized to an early morning dose of immunotherapy, chemo-immunotherapy, I must say, with platinum chemotherapy, or late. Early is they receive all treatment until 3 o'clock in the afternoon, or late after 3 o'clock, which would be very late. I don't know if all the cancer centers go that late. But the remarkable finding, and really this could be a revolution, or it could be confounded by all kinds of things, the progression-free survival in the patients who got the early treatment doubled to 13 months versus 6.5 months. The overall survival had an incredible hazard ratio, 0.43. 0.43 in lung cancer, it's major. when I listened to it and then I listened to the discussion, and one of the commentators said, well, if this was a drug, you would get a standing ovation because the difference is magic. But the audience at ASCO, and I think everybody who reads the paper in Lancet says, is this real? So there's a certain skepticism if there are confounders beside the time of day. Does it really make that much difference if you get your immunotherapy at 9 o'clock in the morning versus 3 o'clock? And what the study did was interesting. They looked for the CD4 and CD8 T lymphocytes, and true enough, the early treatment group increased the CD4 over the course of 3-4 cycles, and the late they decreased the CD4. So CD4 are the T cells that actually chase after the cancer cells. So there was at least a surrogate marker that makes you think that the morning dose pumps up your immune system more. But I'm still skeptical. I mean, this huge difference, doubling the overall survival, it's hard to believe. And so they asked Dr. Sang from China, who was the PI, he asked, how is this possible when immunotherapy has a half-life of 3-4 weeks? Why would 3-4 hours make that much difference? And he kind of shrugged his shoulders. He didn't know. Then he pointed to his French co-investigator, Dr. Levy, who said in beautiful French English, well, pharmacokinetic really doesn't matter. It's what happens in the tumor, so you cannot really judge from the half-life of the antibodies what really happens in the tumor and the microenvironment. But I mean, we're all puzzled. This is a randomized trial, and it was preceded by retrospective trials in France and China on, I think, 600, 800 patients that showed the same effect. And yeah, they were retrospective, and we said, okay, this is confounded because you have maybe more motivated people come in the morning and maybe slackers come in the afternoon, or who knows. It is fascinating, and I haven't made up my mind, honestly, if I now should advise patients to get the immunotherapy in the morning. My clinic, my lung cancer clinic, is in the morning anyway, so they don't have much choice. But I would advise what would be helpful for studies to come to document the time of when the immunotherapy is administered. This should be easy monitored, and then we see in the population of morning and afternoon really makes that tremendous difference in overall survival.
Great explanation, Dr. Kloecker. How do you think we should be able to validate this? Would you like to see chronotherapy studied in other cancers or with single-agent immunotherapy to be more convinced? And if a patient does ask you, should I get my treatment in the morning? Will I do better? Like you mentioned, you are not really convinced. How would you explain that to them?
So this was also discussed at ASCO. Is it true for lung cancer or is it true for other cancers? So I invite other colleagues for GI cancers, you name it, wherever immunotherapy nowadays standard of care, just to look at this in a randomized fashion. Again, I would not say it's a standard of care. Otherwise, I would definitely offer it to all patients. You want to come at 9 or 10 o'clock, or at the latest, maybe at 1 o'clock in the afternoon. So I don't think it's a standard yet. It needs to be more validated. It would be great to have a good biological explanation why 6 hours make that much difference on this treatment. I'm curious to hear what my colleague thinks. So, Dr. Badin, let me pick your brain. What do you think?
As you said, I mean, the difference is remarkable, but what bothers me is we don't know why. I don't think anybody knows why, or, I mean, they can say T cell exhaustions, different infiltration during the day, this and that. But I would say probably all of us agree there is no clear explanation why would that make such a huge difference. At the same time, it's really hard to ignore being a randomized phase 3 study. So Am I going to change my practice? Probably not, because we were in the same boat. Most of our patients who gets infusion therapy, it happens early in the day. We rarely give any treatments after 3 o'clock in the afternoon. We might do supportive care at that point, maybe an IV fluid or IV iron, but really therapeutic intervention rarely happens at our infusion centers. Maybe in busier places like China. I don't know about the situation in Europe or France in particular, but I would say at our multiple infusion centers, rarely patient will receive immunotherapy drug after later in the afternoon. It looked remarkably better. I don't know why. It's hard to ignore, but also it's hard to accept without clear explanation why this is the case. I would say now that with wearable devices and the widely adoption of biospecifics in the clinic, maybe trying to explain why. Maybe look at patient, temperature, heart rate, cytokine release, those kind of different things. If we can just understand why, I think it will make more sense. Right now, we're just all puzzled with this.
That is a great explanation and a great discussion that we had on this trial. So one final question for both of you. What's one takeaway from this recent trials that you think should shape care here in Kentucky over the next few years?
I'll jump ahead. I think the practice has to change when medical oncologists see lung cancer patients. We discussed 2 neoadjuvant trials, and I think it makes sense across Kentucky that if a lung cancer patient is diagnosed by a pulmonologist, to send them to medical oncology and surgery at the same time. If you have a multimodality clinic, that works out great. But I think it's no longer standard of care that the surgeon sees the patient and then cuts the tumor out, and then you see the patient several weeks later and talk about adjuvant stuff. I think neoadjuvant has become the standard of care. So that also means medical oncology has to be on the front line when lung cancer is diagnosed and detected.
To me, I am most excited about screening CT scans and neoadjuvant data. I think between those 2 things, we're going to see huge impact to patient outcomes, and in particular to lung cancer cases in Kentucky. When it comes to screening CT scans, we're always seeing in Kentucky as a state doing great, if not leading, one of the leaders in the country about number of CT scans. And we're always seeing at our 9 hospitals in Kentucky really a stage shift to our earlier stages with the adoption of successful screening program. And number 2 is the neoadjuvant data. We have more and more evidence that simple neoadjuvant therapy really improves patient outcomes, significant improvement, not only to event-free survival, but now we have the overall survival data. Definitely getting oncologists involved early on will make the huge impact. And as long as we have some education toward the navigators, I think every cancer center in Kentucky has access to a navigator, making sure that this patient is being navigated toward medical oncology early on, whether it happens because of a navigator intervention, pulmonologists, or CT surgeons, as long as we can get our hands on them prior to surgery and give them neoadjuvant therapy, chemo-immunotherapy, or targeted therapy. I think we're going to see a huge impact.
Great insights. It seems like early involvement of medical oncology is the key in these situations. It's clear that turning this research advances into real-world practices will be crucial, especially in a high-burden state like ours. I appreciate both of you for sharing your expertise on NSCLC, that is non-small cell lung cancer. Thank you, Dr. Kloecker. Thank you, Dr. Badin, for joining the discussion. Thanks for joining us here on KYSCO Oncology Voices, a resource of KYSCO. If you are looking for more on what we covered today, check out the show notes for some additional information. And while you are there, make sure to hit that follow button to follow along with us. Have thoughts about today's conversation? We would love to hear. You can send us your comments at blawrence@accc-cancer.org. And with that, We'll see you next time.